Imagine being a parent and seeing your baby do this. What do you think this could be due to? Are these tremors? Are these seizures? And if so, what's causing them? Okay, first of all, when you see a baby doing that, no doubt it's going to be scary. But here's a comparison to help you figure out whether or not you're dealing with seizures or tremors. During a seizure, a baby will often have a very abnormal neurological exam, and their neurological exam, often before these movements even start, is abnormal, perhaps high muscle tone or low muscle tone. The other thing is, the movements are very rapid and are considered high frequency when they're tremors or shaking, and convulsions or seizures are low frequency, more rhythmic movements. Importantly, if you touch a baby and they start shaking rapidly, that's more in keeping with tremors or jitteriness. If you touch a baby and the movements don't change or the movements don't start with touch, that would mean it's unlikely to be seizures. And finally, with jitteriness or tremors, what you will find is when you simply put your hand on a limb, they stop. Whereas with seizures, you put your hand on a limb, and although you can overpower a baby because we're much stronger than babies, you will still feel that muscle contract under your fingers. One of the reasons that babies will have tremors or jitteriness has to do with exposure to drugs in utero, in particular opiates. In the last 10 to 15 years, there has been a significant rise in the use of opiate drugs by mothers during pregnancy. This has been accompanied by an increase in the number of babies that we see with jitteriness in the newborn period. I was delighted to take part in a new statement in January of this year by the Canadian Pediatric Society, shown above. This statement marks a major shift in the approach to those who have neonatal opioid withdrawal syndrome, or what we also call neonatal abstinence syndrome. For about 50 years, we have had a focus on using a scoring system called the Finnegan system in order to determine which babies need to be treated with opiates. And although in the past we had a recommendation that you should still use some non-pharmacological attempts to reduce scores and reduce the need for treatment, the reality is a lot of babies have been treated with drugs such as morphine for this condition over time. In addition to recommending the use of a new tool in this statement to help manage mothers and infants who have been exposed to opiates, there was a much greater focus on non-pharmacological measures. Shown here is skin-to-skin care. The use of such things as skin-to-skin care, rooming in, dim lighting, quiet environments, and respecting that babies don't like to be handled when they're sleeping or when they're feeding, has led to a significant drop in the number of babies needing treatment with morphine. The use of something called the Eat, Sleep, Console program is what has really been a game changer for these babies and their families by, again, focusing on non-pharmacological approaches. Rather than using a 21-item Finnegan scoring tool, we now rely on 3 simple questions. Can your baby eat? Can they be consoled? And can they sleep? This is a study out of New Haven, Connecticut, and showed the power of the Eat, Sleep, Console method. Doctors in New Haven decided that there was something wrong with the approach that they were taking. Many babies, 96% of babies in fact, at the start of their analysis, were found to be requiring morphine who had neonatal abstinence. And with rising numbers of exposed pregnancies, they said there has to be a better way. The figure from the published paper that they did using Plan, Do, Study, Act, or quality improvement PDSA cycles revealed a dramatic reduction in the amount of morphine administered with some simple measures. These measures included such things as a focus on rooming in for mother-infant dyads, not requiring babies to be admitted to the NICU simply because they required morphine, and very importantly, a big focus on non-pharmacological measures, as I've talked about before. The black line above demonstrates the use of morphine in these patients over time, and you can see that with each of the different steps that they implemented, a significant drop in the use of morphine happened, starting at 96% of babies and averaging out at a mean of 28%. Judging by these results, I would say that if your baby has tremors or jitteriness and is ultimately found to have this secondary to a withdrawal from an opiate or other drug, you can expect to see the eat, sleep, console method of approaching these babies to be dominant, I think, in the time moving forward.